Hello everyone, I'm Dr. Mohit Kapoor. I'm a first year radio diagnosis JR at AIIMS Bibinagar, Hyderabad, and today I'm going to discuss about the radiology of gastrointestinal tract. So the emerging modalities which we are going to see here are the plain X-rays, barium studies, ultrasound, CT and MRI. In this lecture, we are going to discuss the plain X-rays, barium studies and ultrasounds. So starting with the plain abdominal X-rays, the three views which we use here are erect, supine and decubitus view. The densities of the radiographs are gas, fat, soft tissue, bone and metal. The indication of plain abdominal X-ray are intestinal obstruction, intestinal perforation and imperforate anus. Starting with the intestinal obstruction, the first investigation which we could do for intestinal obstruction is an X-ray abdomen, erect as well as supine. Usually the investigation of choice for children is ultrasound abdomen, whereas for adults we prefer CT abdomen. The feature we see on abdominal X-ray are we see dilated bowel loops with horizontal air fluid level and we cannot see any air in the rectum. Then if we see the small intestine and large intestine obstruction, in small intestine obstruction we can see it's mainly central, whereas large intestine obstruction is mainly peripheral. For the diameters of small intestine obstruction is approximately 3 or more centimeters, where for large intestine it's more than 6 centimeters and more than 9 centimeters for sigmoid. If we can also see volvulus conventus, which is suggestive of jejunal obstruction. Here we can see this step complete volvulus convolutus or step ladder pattern, which is suggestive of jejunum. Normally, if we see ileum will appear as characterless or featureless ileum. And whereas if we talk about large bowel obstruction, we will see incomplete hausturations, which are suggestive of large bowel obstruction. Next, intestinal perforation, also called as pneumoperitoneum. The best investigation is CT for CT. But if we talk about X-rays, then X-ray chest is better than abdominal X-ray, and the most sensitive sign we see is an air under the right hemidiaphragm. We should know we normally see some air below the left diaphragm, which is stomach air, and it should not be confused with pneumoperitoneum. We will diagnose or we will say pneumoperitoneum if we see air below the right hemidiaphragm. Other signs which we see, which are more likely seen in abdominal X-ray are first is the cupola sign, where we see air below the center end of diaphragm. We can also see football sign. We can also see falciform ligament sign, where falciform ligament is more clear because it's surrounded by the air. We can also see Wriggler's double wall sign here because air is present outside as well as inside the bowel, so the outer wall of the bowel is very clear. And we can also see a Dodge cap sign here. This is because there is trapping of air in the hepatorenal pouch, and that can give this appearance, also causes dog cap sign. Next is pseudo-pneumoperitoneum, also called as Chiaritis sign. Like if we see this X-ray, we would think the patient has pneumoperitoneum because we can see some air here, but we should know that this is not air, but this is bowel, which is trapped between the diaphragm and the liver. And we can say that this is bowel because we can see this hausturations between, and this will suggest that this is colon which got trapped here. So this is Chiaritis sign, and it can also mimic as a pneumoperitoneum. Last is invertogram, and this we do to see for imperforate anus. Like here we can see here we put a metal clip over here, and then we send the child for X-ray, and where we can see there is no passage of air toward the anus, or there is no air in the rectum, suggesting the patient has imperforate anus. Now starting with the barium study, it will include barium swallow, barium meal, barium follow through and barium enema. Starting with the barium swallow, we ask the patient to swallow the barium suspension, and then immediately fluoroscopy images are taken. The barium swallow is used to visualize the cricopharynx, esophagus and the gastroesophageal junction. So the normal constrictions of the esophagus are superiorly when at the level of cricocartilage junction with the pharynx, middle when it's crossed by the arch of aorta or the left main bronchus, inferiorly by diaphragmatic sphincter. Zenker's diverticulum, it's a false or a pulsant diverticulum which arises from the Killian's dehiscence. This Zenker's diverticulum, as you can see here, this is the Zenker's diverticulum. It is present between the two parts of inferior constrictor. Two parts of inferior constrictor is above the cricopharynx here and below the thyropharyngeus here. So it's ends like posteriorly and laterally. This is the Zenker's diverticulum, and on radiograph we can say this is the Zenker's diverticulum. Second is the Plummer-Vinson syndrome, also called as Peterson-Kelly-Brown syndrome. The triad for this is esophageal webs, iron deficiency anemia, and dysphagia. So in this we can see these are some filling defects, horizontal filling defects in the esophagus, that are the esophageal webs. So the patient will have esophageal webs. The patient will also have iron deficiency anemia and dysphagia. And this patient has increased risk of squamous cell carcinoma of hypopharynx. Achalasia cardia. So this is this is a motility disorder where we can see there's a failure of dilation of the lower esophageal sphincter, and this will give it a smooth tapering appearance, and the upper segment is dilated, and then as we go down we see a smooth tapering appearance, and this gives a bird beak appearance. So you can see this gives a bird beak appearance here. And there's one more thing, the patient complains of dysphagia, and dysphagia is more of liquids than solids. So if we compare achalasia cardia with carcinoma of esophagus, in this achalasia cardia we'll have a young patient which will complain of dysphagia, and dysphagia will be more of liquids than solids, or it will be equal to solids. And second, we can see this smooth tapering giving a bird beak appearance, whereas in carcinoma esophagus here the patient will have this will be a elderly patient having dysphagia more towards solids than liquid, and the here it will have irregular narrowing, like here in achalasia there was very smooth tapering, but in carcinoma esophagus there will be irregular narrowing, and this gives a rat tail appearance. So we should always know how to differentiate achalasia cardia from carcinoma esophagus on barium scans, on barium swallow. Coming to the next, corkscrew esophagus, and this is seen in a diffuse esophageal spasm. This is another motility disorder, and this is characterized by incoordinated contraction of the esophagus. And here we can see this is the corkscrew appearance or diffuse esophageal spasm. Unlike achalasia, where the peristalsis was decreased or there was no peristalsis, here there is increased and incoordinated contractions. Coming to the next, feline esophagus, here we can see there are transient bands in middle and lower esophagus, and this transient band, multiple transient band, are due to contraction of muscularis mucosa, and this is called feline esophagus because it resembles a cat, like we can see here. And this feline esophagus is associated with GERD, or is commonly seen in GERD, esophilic esophagitis, and or hiatus hernia. Next is Chiart's ring, Chiart's B ring. Here we can see there is another complete circumferential narrowing of the distal esophagus, and this is located at squamocolumnar junction and may be associated with hiatal hernia. Next we have esophageal atresia and tracheoesophageal fistula. Like on the left side we can see this here, we can see the barium was inserted and the esophagus the filling of esophagus stopped at this level, and that showed that there was atresia downwards, atresia. So this was esophageal atresia, whereas here we can see this was the esophagus, and we can see some contrast was also going towards trachea. That means there was some connection between the esophagus and trachea. So this was patient having tracheoesophageal fistula. Coming to the next, hiatus hernia. So hiatus hernia can be of two types. It can be sliding type or it can be rolling type. In sliding type, the gastroesophageal junction gets pulled up from the diaphragmatic junction and can go upwards, and this is called a sliding hernia. Whereas in rolling hernia, instead of G junction, some other part will go upward. It could be some fundus of the stomach or anything. It may get pulled up and comes out through the diaphragmatic opening, and that is called as rolling hernia, like here. And the rolling hernia has much higher risk of volvulus and ischemia. Coming to the second, barium meal. So barium meal is used to visualize stomach and duodenum, and it visualizes till duodenojejunal junction. So first is the congenital CHPS, congenital or infantile hypertrophic pyloric stenosis. Here we can see there was an infant approximately 6 to 8 months old, 6 to 8 weeks old, and presented with non-bilious vomiting. And what we can see here, there is hypertrophy of pylorus muscle. So there is hypertrophy of pylorus muscle, which will cause narrowing of the pylorus. So there is hypertrophy of the pyloric muscle, which will cause narrowing of the pylorus, and this will cause a gastric outlet obstruction. And on ultrasound, this will we can see thickened pylorus muscle here. Like here we can see the pylorus muscle thickness has increased. And if we can see if thickness is more than 4 mm, that is very characteristic of CHPS. And second is length, and this channel length will be more than 16 mm. And if we do x-ray, then we will see single bubble sign. And there are multiple signs which we see on contrast, like this is mushroom sign, diamond sign, shouldering sign, beak sign. So like we said, on x-ray CHP is present as a single bubble sign, whereas if the patient has duodenal atresia or annular pancreas, we will have double bubble sign, whereas we find triple bubble sign in jejunal atresia. So single bubble sign in CHPS, double bubble sign in duodenal atresia and annular pancreas, triple bubble sign in jejunal atresia. Coming to the next, barium meal follow through. Barium meal follow through is also known as enterography and is used to visualize small bowel. It is used to visualize small bowel up to ileocecal junction. And we should also note that on X-ray, jejunum will have a feathery appearance, whereas ileum will be featureless. First is ileocecal junction TB. So ileocecal junction TB, this is a secondary TB, secondary to patient swelling his own sputum, patient having primary pulmonary TB and swelling his own sputum, and that can lead to ileocecal junction TB, intestinal TB, ileocecal junction TB. And here you can see there is fibrosis of the ileum, and this fibrosis of ileum is giving a string sign. Further, this fibrosis will pull up the cecum, and then this will cause pulling up of cecum. Further, there is thickening of ileocecal valve. This is known as Fleischer sign, and this all configuration gives a gooseneck deformity appearance. Next is inflammatory bowel disease. We have two main categories under this: Crohn's disease and ulcerative colitis. Crohn's usually start from the terminal ileum and it goes upward, and it goes it starts from the terminal ileum and it goes downwards, and it follows a skip pattern approach. So we find skip lesions here, and we can also see cobblestone appearance of mucosa, aphthous ulcer. Whereas ulcerative colitis, it starts from rectum and it goes upward, and here if we have contiguous or continuous involvement. Further, we can see the inflammation in Crohn's disease is transmural, whereas in ulcerative is partial. It is only mucosal or submucosal. Radiography, we can see string sign. Like here, we can see string sign because of fibrosis, and we can also see this will be this string sign will suggest strictures of fibrosis, but this will be non-continuous. There will be skip lesions here in Crohn's disease. Where ulcerative colitis, we will find lead pipe colon. Like here, we can see lead pipe colon on X-ray. Further, we should also note that in Crohn's disease there are increased risks of fistula, abscess, and obstruction, whereas in ulcerative colitis there is a very high risk of toxic megacolon. Coming to the last, barium enema, and this is done for large bowel. So here the contrast is injected from the rectum, and it goes upward, and it is goes upward until we see ileocecal junction. So the study is completed when the contrast is the ileocecal junction. So first we are going to see is intussuception. So in intussuception, we can what is intussuception? It is the telescoping of one bowel loop into another, and the most common site is ileocolic type, where due to hypertrophy of Pierce patches, which is commonly seen in children, it will act as a lead point upon which intussuception occurs. Most commonly, if we do ultrasound, we will find target sign, donut sign, or pseudokidney sign, whereas the gold standard is barium enema or saline enema under ultrasound guidance. On contrast, we see a claw sign. On ultrasound, we see a target or a donut sign, and the management of them is barium enema, saline anemia. Barium anemia is done under fluoroscopy guidance, where saline anemia is done under ultrasound guidance. So this is intussuception since when the patient was operated. Coming to the next, volvulus. Volvulus is twisting of the bowel loop on its own axis. So we should know about two main volvulus, that is the cecal volvulus and the sigmoid volvulus. If we see this is the bowel and this is a sigmoid volvulus, and sigmoid volvulus, we see that it twists. Sigmoid volvulus is usually seen in patient having constipation, and due to constipation and thin mesentery, thin and long mesentery, the bowel will twist on itself, and then this will cause sigmoid volvulus. And we can see the direction in sigmoid volvulus is anti-clockwise direction. So, and second in cecal volvus, this is the cecal volvus, and here the direction is clockwise. So here the direction is, this is the cecal volvulus, and like here, and this goes like this. So this is clockwise. Sigmoid volvulus is anti-clockwise. Uh, the basic funda here is the all the rotation of them is from out to in, and from sigmoid also out to in. Like if sigmoid is here, it will go out here and in here, and cecum it's here and it will go out here and inside here. So if this is the clockwise direction, so this is going like this, that is cecal volvulus have clockwise direction, where sigmoid it goes like this, and normal clockwise is like this. So sigmoid volvulus will have anti-clockwise direction. So we should know that sigmoid volvulus will have a coffee bean appearance or coffee bean sign, where cecal volvulus will have embryo-like appearance. So this is known as embryo sign. So coffee bean sign in sigmoid volvulus and embryo sign in cecal volvulus. Coming to diverticulitis, and here we have multiple outpouching giving a sawtooth appearance to the colon, and this will give us sawtooth appearance to the colon. So this is diverticulitis. Next is colon cancer. Colon cancer, there is a formation of stricture and narrowing, giving a apple cord deformity to the colon. This is mostly seen in the left part of the colon, that is the descending part of the colon. Last we have Hirschsprung disease. Hirschsprung disease is a functional obstruction. Here we can see this end is contracted, or this part has loss of ganglion sign. So this is contracted. This is a ganglion or contracted part, and this proximal is all dilated normal part, and between the dilated part and the contracted part there is some transitional zone. So Hirschsprung disease is characterized by a proximal dilated part, a transitional zone, and a contracted ganglion part. Now coming to the last topic here, that is ultrasound abdomen. So ultrasound abdomen, the first we are going to see the basic of how the normal organs we see on the ultrasound, and then we are going to see various some pathologies which we see in the ultrasound. So first, starting with, we will put our probe center, and first thing we will see is pancreas. So this is the splenic vein, and surrounding it we can see the normal pancreas. This is the head, this is the body, and here we can see this tail end. Usually tail part is obstructed, not seen because it is obscured by the bowel gas here. So here we can see this is the splenic vein, this is the superior mesenteric artery, this is the left renal vein, inferior vena cava, and aorta, and this is the normal pancreas vertebra. So these are on the normal appearance of the pancreas. Then we go towards right, then we go shift from here to right, and here we can see normal liver like this, and below the liver this we can see this is the right kidney, and between them we have hepatorenal pouch. So we see liver, kidney, and the hepatorenal pouch in between. Then so if we see, this is the right kidney, this is the renal sinus, and this is the cortex. So cortex and sinus. Then if we see liver little properly, then we'll say this is the inferior vena cava, like we started. Like here we will see inferior vena cava when we put pancreas over here. So here will be see inferior vena cava. So we're talking about this point. So if we come to that point, then we will see there is a division giving a left hepatic vein, middle hepatic vein, and right hepatic vein, and this is known as a bunny sign. Further, if we orient our delta probe a little, we will see normal portal vein, and above the portal vein we will see this choledical duct or CBD. So we will see portal veins, we will see left, middle, and right hepatic veins, we will see portal veins, and we will see CBD. Further, if we see in the portal vein, the blood flow is hepatopetal. So in portal it's hepatopetal, whereas in hepatic it's hepatofugal. So in hepatic veins it's hepatofugal flow, and hepatofugal flow, whereas in portal it's hepatopetal flow. Hepatopetal means it's going toward the liver, so here is hepatopetal flow. Hepatofugal means it's coming from the liver, so in hepatic veins hepatofugal or from the liver. Then if we see, we can see gallbladder. So this is the normal distant bladder, and if we use comparison we can clearly see the gallbladder. Like if we see here only, if we tilt our probe little, then we can see the gallbladder here also. So if either we can see from here, like if we are seeing pancreas, we can just tilt our probe to a little right and we can see the gallbladder, or if when we are at the junction of left liver and kidney, we can just tilt our probe to see the gallbladder here. So this is the normal gallbladder. And if we go right, we can see again coming to the kidney. So this is the kidney, this is the cortex, these are the small renal pyramids, and this is the all collateral system. And then we go from here to downward, we will see urinary bladder here. Then we go towards left side and we can make out spleen, and below that we can also make out kidneys. So here we can see spleen clearly, and if we go downwards we can also make out the left kidney also. Next, if we have to look for appendix, we go to the McBurney's point and then we give a little pressure and we can see appendix here. We will see normal ileocecal junction and the appendix coming out from it. And this, if we tilt our probe to long or change the orientation of the probe from transverse like this to longitudinal like this, we can see appendix in this circle pattern. So this, you can see this appendix here and here. So this is the normal appendix. Now coming to some ultrasound appearance of some pathology which we see. If we see something which is hypoechoic, then it could be anechoic or it could be hypoechoic with some echoes within it, or it could be isoechoic, or it could be hyperechoic. If it's hyperechoic, it could be hyperechoic with comital artifacts or hyperechoic with posterior shadowing. If it's anechoic, that means there is collection of clear fluid. And if it's hypoechoic with echoes, that is there is some turbid fluid. If it's isoechoic, that means it's some solid organ. If it's hyperechoic with comitic artifacts, then it's air. If it's posterior shadowing, then it's bones or calculus. So comital, air; posterior shadowing, bones, calculus; isoechoic, solid; anechoic, fluid, clear fluid; hypoechoic, turbid fluid. So coming to all of them, first is the anechoic. I told anechoic means clear fluid. It can be some simple cyst, or it could be normal gallbladder, or the normal bladder or gallbladder. So this was the liver. We can see some anechoic cysts here. These are simple cysts. Same goes for kidneys. We can see this was the liver, this is the right kidney, and here we can see an anechoic simple cyst. And this is the ovary of the patient, and ovary we can also see a simple cyst. Here we can see normal anechoic bladder. Here we can see normal anechoic gallbladder. Coming to hypoechoic with some echoes, that means it's a turbid fluid. Turbid fluid means that if the cyst is no more simple, it's infected cyst, or there is formation of abscess. Like in this, we can see this is the bladder, and here we can see in the bladder this mucosal wall irregularity, thickening of the wall, and there is irregularity also, and inside the bladder also we can see some internal echoes within. So this patient probably has cystitis. And coming to this one image, this was liver and this was the gallbladder, and here we can see this thickening of gallbladder wall, and there is some echo seen within the gallbladder, that is probably suspecting of cholecystitis. So this patient probably has cystitis, this patient probably has cholecystitis. So that is the bladder is infected, that is the gallbladder is infected. Coming to this one part, this we can see this is an ovary, and in ovary we can see there is some internal echoes within it, and this is a example of hemorrhagic cyst. And here we can see this is the liver, where there is formation of some hypoechoic lesion, and these are suggestive of pyogenic liver abscesses. So next we have hyperechoic with comital arteries, and I told you that is bowel. So we can see hyperintensities or hypoechogenicities, and behind them we can see comital artifacts like this. So these are suggestive of intestinal gas. Then we have hyperechocity with posterior shadowing, and that was suggest stones. Like here we can see this was the gallbladder, and there was some hyperechogenicity, and behind them we can see shadowing. So these were the GB stones. Here we can see kidney, there is some hyperechogenicity here, and behind this there is shadowing. So this is renal stone. So this was GB stone, this is renal stone, and then we see urinary bladder, and here we saw some hyperechogenicities, and behind them some posterior shadowing, and this is a suggestive of urinary bladder stones. Then one more interesting case for you. So this patient, this is the ovary of patient. We can see normal small anechoic follicles in the patient, but there is some big lesion here, and this is somewhat isochoic to hyperechoic mixed lesion we can see, and there is some hyperechogenicity here, and behind that we can see shadowing, and that would suggest there is some calcification here, and this is a Rokitansky nodule, which is hyperechoic nodule, and behind this because there is calcification we can see posterior shadowing. So this is suggestive of a dermoid cyst in the ovary. So this was the modalities which I want to discuss in this lecture with you. Thank you very much.